In this second part of the cardiovascular system lecture, we'll be looking at cardiac output as well as electrical activities of the heart. So first, cardiac output. Cardiac output is a measure of how effective our heart is at pumping blood, ejecting blood to the pulmonary and systemic circuits. And this diagram looks at the factors that influences cardiac output. Okay, so you can see how effective heart is at ejecting blood has to do with both heart rate as well as stroke volume. Stroke volume is amount of blood ejected from the heart within one heartbeat. Okay, and we'll look at that more later. But using this diagram, you can answer questions like, how can our heart rate be increased? Right? And how can we maximize or optimize the stroke volume? Okay. And so, well, you can answer these questions by looking at this diagram, but once you really understand the concepts behind these, you should be able to answer these questions without looking at this diagram. So this part of the lecture now is just focused on understanding this diagram. This is a reminder of the anatomical difference between your right and left ventricles. Normal pressure inside systemic circulation is much higher than pressure inside the pulmonary circuit. And so the muscles in your left ventricular wall is much thicker than that on the right ventricular wall. Okay, so that's because pressure within the systemic circuit is much higher, so your left ventricle has to be able to generate greater pressure in order to propel blood through that circuit, compared to the right side pumping blood into the pulmonary circuit. So both sides pump the same volume of blood, and these circuits are in series. Now, cardiac output measures the volume of blood pumped by each ventricle in 1 minute. And usually we're looking at just the left ventricular cardiac output. So if it's not specified, then that means we're looking at the left ventricular cardiac output. And that's because your left ventricle's cardiac output concerns how much blood and therefore oxygen the systemic circuit is getting. Okay. Now, cardiac output is influenced by heart rate and stroke volume. And you can work out the units, and you'll see that heart rate is measured in beats per minute. Stroke volume is volume per beat. Okay, and it should make intuitive sense that when you multiply the two, right? And this is the volume ejected by your heart for every heartbeat. And then you multiply that by however many beats your heart is able to pump per minute. That gives you the amount of blood ejected by your heart in that 1 minute. So this is a measure of the how effective your heart is able to eject blood in 1 minute. And at rest, on average, your heart pumps about 5 liters of blood, okay, per minute. Okay, so the maximal cardiac output or maximal volume of blood ejected by your heart in 1 minute is usually 4 to 5 times compared to the resting cardiac output. Okay, and these aren't numbers that you have to memorize, but you can see that highly trained athletes can have significantly higher efficacy in ejecting blood from their heart per minute compared to, the rest of us. Cardiac output being the product of stroke volume and heart rate. That means that you can increase or decrease cardiac output by influencing either stroke volume or heart rate or both. Okay. And so if we take a look at this diagram again, we see that heart rate, okay, the influences for heart rate is pretty simple. Usually autonomic nervous system, increasing sympathetic activity increases heart rate, and then we can increase cardiac output that way. Okay, so when your heart is untrained, if you're not a highly trained athlete, your heart mostly utilizes this mechanism, right? Increasing your sympathetic activity, causing your heart rate to rise when you start running. Okay, and then a decrease in parasympathetic activity also contributes to increase in heart rate and thereby increasing cardiac output. But what are some of the factors that contribute to changes in stroke volume? And this is the next part that we'll look at. So stroke volume is measured as the volume of blood ejected by your ventricle in 1 beat. And normal adult stroke volume is generally around 70 milliliter per beat. Okay, and end-diastolic volume, we recall that this is the volume of blood left in your ventricle at the end of its relaxation. So this is the maximal amount of blood in your ventricle throughout one cardiac cycle. End-systolic volume, on the other hand, measures the least amount of blood, the minimal amount of blood that's found within your ventricles throughout the cardiac cycle. So if you take the difference between the two, okay, it should make sense that stroke volume, you'll get stroke volume, okay, which is the amount that's ejected within that one heartbeat. Okay, so if you take the difference, do the calculation, on average, adult stroke volume is around 70 milliliter per beat. The end-diastolic volume is affected by the length or the duration of ventricular diastole, as well as the venous pressure. Okay. And the mechanism is that when you decrease heart rate, it allows more time for the filling of ventricles during ventricular diastole. And with more time for filling, that means more volume gets returned back to the ventricles, and so increasing the end diastolic volume. And in terms of how venous pressure affects end diastolic volume, it's that when we increase the venous pressure, it increases the pressure gradient between our superior and inferior vena cava with our heart chambers. And that greater pressure gradient pushes blood into the ventricles. Okay, and that increases the venous return back to ventricles and thereby increasing the end diastolic volume. There are three main factors that influences our stroke volume. Stroke volume, remember, is the amount of blood ejected by your heart in one heartbeat. So the three factors are preload, afterload, and contractility. Contractility measures the contraction force at a given muscle length, and this has to do with the amount of calcium released during that excitation contraction coupling. So cardiac muscle contraction shares a lot of similarity with skeletal muscle contraction. Okay, and so if you recall from a skeletal muscle lecture, there is that excitation contraction coupling that leads calcium to be released from its sarcoplasmic reticulum. Okay, so the amount of calcium binding to troponin, moving the tropomyosin, will determine how much interaction we have between the myosin and actin. Okay, and thereby influencing our contractility. Preload is the amount of tension within the ventricular cardiac muscle just prior to contraction. So it measures the degree to which cardiac muscle cells are stretched just before they contract. And it's explained by the length tension relationship, also called Frank-Starling relationship, which we'll take a look at on the next slide. Finally, afterload. Afterload is the back pressure coming from the systemic and pulmonary circuit that's acting as resistant against the ventricles trying to pump out the blood. So it's essentially the arterial pressure that the ventricles must overcome in order to eject blood. Let's first take a look at preload, which is the first primary factor into the stroke volume. Preload measures the degree of stretch of heart muscle just before its contraction. And cardiac muscle, similar to skeletal muscle, those exhibit a length tension relationship. And this length tension relationship basically states that there's an optimal overlap between actin and myosin that allows for the maximal tension and contraction force. Okay. And so too little of length, too much overlap, too little overlap are both not good. We're able to generate the greatest amount of force with this optimal resting length. So the most important factor in preload stretching of the cardiac muscle is venous return, meaning the amount of blood returning to the heart. Well, why is that? Okay, so if you think about it, when you increase venous return, okay, in other words, increasing the end diastolic volume or EDV, it distends or stretches the ventricles. When you stretch on the ventricle with that extra amount of blood in there, okay, according to this length tension relationship, it increases the force of contraction that our heart's able to generate. Okay, with that, our heart's able to pump with greater force, and that then lead to increased stroke volume. Okay, and so we can increase venous return by both slowing down the heartbeat and also exercise to increase that venous return. So slowing down heartbeat allows more time for filling the ventricles, and exercise, right, will those muscular pump, right, will bring more blood back to your heart, both of which distends the heart to a greater extent. And because at rest, cardiac muscles are shorter than optimal length, and so when you slow down heartbeat, allowing for more venous return, or use muscular pump to bring more blood back to the heart, that allows the heart muscle cells to then stretch to its optimal length, okay, and increasing the contractility of the heart. This is that muscular pump we talked about before. Your veins have one-way valves in them to allow unidirectional flow of blood. Okay, and so when you exercise, skeletal muscles press on the vein, and so that brings the blood against gravity upward back to your right atrium. So this is one mechanism for which we can increase venous return. The second factor that influences stroke volume is contractility. Okay. So whereas preload deals with being able to optimize the force of contraction by optimizing the overlap between actin and myosin, contractility measures the contractile strength at a given muscle length. So it's independent of the degree of stretch in the cardiac muscle, and also therefore independent of end diastolic volume. When you increase cardiac contractility, okay, that means you're also going to have less blood left within the heart, within the ventricle, especially at the end of systole. Okay. And under sympathetic stimulation, when you increase sympathetic activity, epinephrine stimulates increased calcium influx. More calcium binding to troponin, right, means more tropomyosin exposes the myosin binding site on actin, allowing for more cross bridge formation between actin and myosin. That third major factor influencing stroke volume is called afterload. Afterload measures the back pressure coming from the arterial system, pushing back against the ventricle. So it's also the pressure that the ventricles must overcome in order for them to eject blood. Aortic pressure usually around 80, pulmonary pressure much lower. Okay, it's usually about 10 millimeters mercury. So when you have hypertension or atherosclerosis, meaning the plaque formation within blood vessels that narrows those blood vessels, that can really significantly increase the afterload. Okay. And so that's why hypertension, chronic hypertension in your body can be so damaging. It's because when you have higher blood pressure, that means your heart now has to work harder, contract harder to eject blood. Okay, so basically hypertension, atherosclerosis increases afterload. That back pressure preventing your ventricles from ejecting blood. And through that, it increases the amount of blood left in your heart at the end of systole. Okay, and that also translates to less blood being ejected in that one beat, meaning reduced stroke volume.